And then looking at macular edema. So macular edema is a non-specific term for any time you have fluid within the macula. Diabetic macular edema is a lot of times what we see, and you're going to see these little pockets of thickening on the retina map, which correlates to the quantitative retina map, and of course correlates with what we see in the B scan, where we see these retinal cysts, and you can sometimes see exudates along with it as well. And then the left eye is very similar, though a little more mild. Pseudophakic cystoid macular edema, so in patients who have had cataract surgery and then end up getting edema, will also look very similar. You're going to have that thickening on the retina maps, and that's going to correlate with what you see on the B scans. It gives you a great view of the petaloid cysts, and that will help you distinguish this form of edema from maybe diabetic macular edema or something else. Looking at these back-to-back, so a case of pseudophakic edema and diabetic macular edema, you can see that the diabetic macular edema on your right is much more irregular, and it's not centered on the fovea and doesn't have that nice petaloid appearance. Though if you look at just the retina maps, they look very, very similar, and I don't think you can really distinguish it based just on that. Looking at macular edema secondary to a branch retinal vein occlusion, it's going to be very similar to diabetic macular edema. It's going to be asymmetric, but it's usually going to follow along with where you have the retinal vein occlusion. So it's important to see where you have that vascular remodeling and which actual vessel was occluded. And that'll help you figure out, oh, is this diabetic macular edema, or is it branch retinal vein occlusion, or something else going on? Now, choroidal neovascularization, a case like this, you probably don't even need OCT to figure it out, because this is a really tremendous net here with a lot of edema. And you can see there's the hyperreflective net, which is all the blood vessels that are growing along with the fibrous tissue. And then you have the fluid, and then you also have some exudation. Looking at a much more mild case, so this case on fundoscopy, you might see maybe a little bit of blunting of the foveal reflex, but it won't be a traumatic hemorrhagic response like you would in this case. So again, looking here, you have that small net, and then you have the fluid right next to it. And this is important to make sure, one, that you know exactly what you're looking at, so you know to send this over for treatment. But two, you can also co-manage this with the ophthalmologist to see if anything is improving, worsening, or staying the same. And that can sometimes be important when you have to send the patient back. Central serous chorioretinopathy is another one of those conditions where it might be hard to tell exactly what's going on with just fundoscopy. Looking at the OCT, we have the edema on the B scan and on the retina map. And then we see this little PED, but it's not really a hemorrhagic PED like you have in choroidal neovascularization. Very often you'll have central serous, you'll have the serous detachment of the retina and then also of the RPE. But it's very, very important to make sure that it's not a vascularized PED, because that can happen in these cases as well, though it's more rare. Looking again at a progression map, which is important for central serous, because initially that's how we manage these patients. We just sort of wait it out a little bit, especially if it's the first time that we notice that this patient has central serous. Unfortunately, in this case, this patient ended up actually getting worse after a few weeks. And we can see the edema on the left on the initial visit, and then the worsening edema on the right. So this patient I actually sent over to retina so they could possibly offer some treatment. Unfortunately, this patient didn't go to retina and eventually came back to me. So that worsening edema foveally actually improved, but then he ended up getting another area of serous detachment superior to the fovea. So he went to retina the second time I sent him. An important masquerader for macular edema is MACTEL type 2. These patients a lot of times will have little dot hemorrhages temporal to the fovea, but when you do an OCT on them, they don't really have any retinal thickening. But they do have these little retinal cysts which sort of look like early edema. But when you look at the thickness maps, it's actually retinal thinning and atrophy. A good way to tell the difference between MACTEL type 2 and macular edema is that these patients actually have this what we call internal limiting membrane drape, where the internal limiting membrane just sort of drapes over these little retinal cysts, and there's not going to be any thickening of the retina. It's actually going to be atrophy. Something that you won't really see too often, but it's another potential masquerader of macular edema, is choroidal folds. And these patients, they look very strange in fundoscopy. They sort of have these darkish bands going across the fundus, and you're not really sure what to make of it. It looks like maybe it's thickened, it looks like maybe not. Really hard to tell. So when you do an OCT scan, if the choroidal folds are horizontal, you don't really see much. So looking at our top OCT, you don't really see too much. Maybe a little irregularity of the RPE, but definitely no edema or anything like that. But then when you do a vertical scan, and you're actually going through the choroidal folds, you can really see all those changes in outer retina. But again, there's no fluid accumulation, and really it's just a little disruption of the choroid and then the retina as well. Some of these cases could be idiopathic, especially if they're symmetric, but it's important to make sure it's not due to scleritis or retrobulbar mass.